I'll hand things over to Dr. Schuchat for an update from the CDC. Dr. Schuchat?
Thank you. Well, thanks so much. I'd like to start out by saying it's a difficult and uncertain time. We, along with our partners around the country and around the world, have been confronting a dynamic, rapidly evolving situation. I'd like to let Americans know that CDC and our nation's public health agencies are preparing every day for this type of situation. Preparedness started long before this outbreak. The U.S. government's response to the spread of the novel coronavirus into our country began as soon as reports of an unidentified flu-like illness emerged from Wuhan, China. The U.S. has been implementing an aggressive containment strategy that requires detecting, tracking, and isolating all cases as much as possible and preventing more introductions of disease, notably at ports of entry. We've restricted travel into the U.S. and have issued multiple travel advisories for countries currently experiencing community spread. Our travel notices are changing almost daily as we get new information. And we believe these precautions are working. So far, as Secretary Azar described, our public health system has detected 14 cases in travelers or very close contacts of travelers here in the United States. Among passengers repatriated by the State Department from Wuhan, China, and from the Diamond Princess, there are an additional 3 and 40 cases. The fact that we have been able to keep cases to this low level is an accomplishment, especially given that we are unfortunately beginning to see community spread in a growing number of other countries. Based on what we know right now, we believe the immediate risk here in the United States remains low, and we're working hard to keep that risk low. But we must use this time to continue to prepare for the event of community transmission in the United States. Part of that preparation is educating the public and our state, local, and private sector partners about what transition from aggressive containment measures to community measures or community mitigation would look like should we end up there. Under our current aggressive containment posture, patients infected with the coronavirus who have mild or no symptoms are being placed in healthcare facilities for very close observation and isolation. That intensive level of medical care is not typically needed. As we've watched these cases and learned over the past several weeks, we realize that other approaches to management are likely fine. Outside this period of aggressive containment, the usual and appropriate care for most patients who develop the novel coronavirus or COVID-19 would be management at home through home isolation, with use of healthcare facilities only as needed for those who have severe presentations, the elderly, those with medical conditions requiring closer observation. We will maintain for as long as practical a dual approach where we continue these measures of aggressive containment to this disease, but also employ strategies to minimize the impact on our communities. However, current global circumstances suggest it's likely that this virus will cause a pandemic. In that case, risk assessment would be different, and new strategies tailored to local circumstances would need to be implemented to blunt the impact of the disease and further slow the spread of the virus. What these interventions would look like at the community level will vary depending on local conditions and on the emerging information about how severe the virus may be. Now, it's not so much a question of if this will happen anymore, but rather more a question of exactly when this will happen and how many people in this country will become infected and how many of those will develop severe or more complicated disease. We have been preparing to address this type of threat and limit the impact on our communities for many years. As some of you heard from Dr. Messonnier of the CDC today, we've begun laying out for the public what it will look like to mitigate the spread of the virus. There are obvious common sense tools like good hygiene, social distancing, things like staying home when you're sick, things we talk about during a difficult flu season, or things that we talked about during the 2009 H1N1 pandemic. We will be transparent with the public about these measures and the potential that these tools will be necessary. There is literally a playbook for the use of these tools, and one that the states and local public health have exercised. We are committed at the CDC and across HHS and the U.S. government to radical transparency, to making sure we're sharing what we know when we know it, and we're giving you a sense of what the future may hold. I'd like to now turn things over to Dr. Fauci for his update.
Thank you very much, Ann. I'm going to give you a very brief update on the countermeasure development that I introduced to this audience on a number of occasions over the past couple of weeks. And the first regarding the issue of vaccine. You might recall that I had mentioned when we first introduced the topic of vaccine that very shortly after the sequence was put on a public database, we began a vaccine development program, which was one of several supported both by the NIH as well as BARDA from ASPR, and even independent individuals that we have been involved in collaborating with for a period of time. One of these vaccines, I think, serves as the prototype of the timing of what we were talking about. You might recall I had mentioned that from the time we had available sequence, we would hope to be in clinical trials within 2 to 3 months. And I said, barring any glitches, that would be the fastest ever in any vaccine that we've gone from the identification of a pathogen to putting it into a human in a phase 1 trial. Well, I'm happy to report to you this afternoon that we are on time at least, and maybe even a little better. The gene has been expressed in the platform, in this case a messenger RNA. The material has been produced. It's been put into mice. It's immunogenic. And it's now getting ready to go through the regulatory issues of getting it to go. So I would project that we would be in a human trial, I would say within a month and a half, and I had thought that maybe cut a week or so off. Again, hopefully no further glitches. Now, the thing we need to understand, because we want to make sure people don't get confused, that getting a vaccine into a phase 1 trial within a 3-month period, you need at least 3 to 4 months to determine if it's safe and whether it induces the kind of response that you would predict would be protective. Once you do that, you graduate to a much larger trial. The N of the number of people in the phase 1 trial is 45. When you go to a phase 2 trial, you're talking about hundreds, if not thousands of individuals to determine efficacy. That is a trial that we would have to conduct in those countries and those areas where there's active transmission. That itself, even at rocket speed, would take at least an additional 6 to 8 months. So when you're talking about the availability of a vaccine, even to scale it up, you're talking about a year to a year and a half. Now, you shouldn't be discouraged by that, because it is certainly conceivable that this issue with this coronavirus will go well beyond this season into next season. So a vaccine may not solve the problems of the next couple of months, but it certainly would be an important tool that we would have, and we'll keep you posted on that. Secondly, and finally, the issue of therapeutic interventions. There are a number of candidates that we are now looking at that have shown some suggestion, either in vitro, in an animal model, or some empiric trials that were done during the MERS outbreak. One of these, and there are several that we're considering, is called remdesivir, which is a nucleotide analog that is produced by Gilead. Today, as I speak, there are 2 major clinical trials going on in China, which are randomized, controlled trials, which means that we will get an answer whether or not it works or doesn't work, I think, within a reasonable period of time. An identical copy of that trial is now being implemented in Nebraska with our colleagues who are taking care of the individuals who were taken from the Diamond Princess and brought back here, in addition to our colleagues in Japan. So I'm optimistic that we will at least get an answer. If we do have a therapy, that really is a game changer, because then we could do something from the standpoint of intervention for those who are sick. So hopefully I'll get the opportunity in the future to continue to update on these interventions. Thank you.